Hello, thanks for joining us today for the next presentation in our series of webinar forums on managing stress. This is a joint production of the Department of Psychiatry, the University of Iowa Hospitals and Clinics COPE team, and the University of Iowa Employee Assistance Program. I'm your facilitator, Dr. Laura Fuller from the Department of Psychiatry. Before getting started, I have important information to share with you about this program. This webinar is provided for educational and informational purposes only and does not constitute providing medical advice or professional services. If you think you may have a medical emergency, dial 911 or go to your nearest emergency room immediately. No provider-patient relationship is created by this webinar or its use. Neither the University of Iowa nor its employees nor any contributor to this webinar makes any representations or warranties, express or implied, with respect to the information provided herein or to its use. We're excited that you've joined us today. If you're watching the live stream version of this program, there will be time for a limited number of questions at the end of the presentation. Please use the chat function to submit questions. A recording of this webinar and further resources will be available at the Loop on the hospital website. Our presenter today is Dr. Arwa Aburizik, Clinical Associate Professor of Internal Medicine and Psychiatry. She's the director of the Psychosocial Oncology program at the Holden Comprehensive Cancer Center. She established the Behavioral Oncology Clinic at UIHC in 2013 and launched therapy groups for cancer patients and caregivers, and she continues to facilitate those. Given her dual training in medicine and psychiatry, she also attends on the medicine psychiatry unit at UIHC, a unique inpatient unit where patients with combined medical and psychiatric morbidity are hospitalized. Today's program is about moral distress and moral injury. This is an interesting topic that originally emerged from accounts of distress following wartime experiences. Now, though, instead of a military action, the soldiers are all of us, healthcare workers, administrators, and people doing all kinds of other jobs such as food prep, cleaning, and many other things. And the enemy is COVID-19. On the battlefield, if everybody had all the necessary weapons and supplies and a foolproof plan for how to defeat the enemy, it wouldn't be much of a battle. However, in this time of COVID-19, there isn't a roadmap to sure victory, and supplies are limited. We all have jobs to do, and we're all doing the best that we can with what we have. Today's presentation acknowledges that in situations like these, it is possible for us to feel at odds with ourselves and at odds with others, or with systemic variables. And there are many valid definitions of what doing the right thing is. A lot of the current interest in moral injury is stemming from places like New York, which have been hard hit by COVID-19. Thankfully, we are not in such dire straits at this time. Still, the topic of moral injury has been suggested by multiple people for one of these wellness forums. As we figure out how to take care of ourselves and one another at this time, it's relevant to learn about moral distress and moral injury and acknowledge that they are a possibility, and then talk about how to prevent or mitigate them. This idea made sense to us with the overall message that we are in this together. During her presentation, Dr. Aburizik will talk about difficult decisions in this time of COVID-19, important concepts to understanding the topic of moral distress and moral injury, and ideas to help people with the impact of the distress that they may be experiencing. Here to tell you more without any more ado is Dr. Aburizik. Thank you.
Hi, and thank you, Laura, for the introduction of the topic and for introducing me. And thanks for the invite to participate in the wellness webinars. Thanks to the Department of Psychiatry and the COPE team and the Employee Assistance Program for creating this wellness series. So the reason that we are talking today about moral injury in the context of COVID-19, like Laura said, is that this pandemic constitutes an unprecedented time, which really has changed the way we do things at work in medicine. In some states and in other countries, The COVID-19 pandemic has really stretched the hospitals to their limits. And in some places, it has caused shortages of essential medicines, of personal protective equipment, or hospital beds and ventilators, and even staffers. Some workers in the healthcare have had to perform their already challenging jobs in more constrained manner. They have watched vulnerable patients suffering and co-workers struggling, and they themselves may have not been able to perform their jobs at an adequate level. And it is in this kind of setup that moral injury is possible, where we simultaneously know what to do and how to care for our patients, but we're unable to perform our duties at our best given the constraints or that are beyond our control. So let me take you to the front lines at UIHC and give you some examples of how people have described their reality while taking care of COVID-19 in our institution. So on this slide are some quotes from our own workers. The first one is from somebody that works in the intensive care unit. He basically said, you know, patients in the intensive care unit are sicker than before. We've always used to be bursting at the seams with the quantity of patients, but at this time, the acuity is much higher. Many of our patients have significant multi-organ failure. Another person from the ICU also said that it has been tense for everyone. The level of concentration is really tiring. Looking at patient through glass and breathing through a filter all day really takes a toll on you eventually. Somebody said that, you know, this is a sad time for everyone. People are isolated in their rooms, and no visitors are allowed to see patients, whether they have COVID or not. We have had to renegotiate the meaning of full code. We've always wrestled with the permissibility of resuscitating patients that are terminal without much hope of a good quality of life after a resuscitation. But at this time, we are not going to risk endangering our own staff by resuscitating people who are COVID 19 positive in futile ways. And one of the hospitalists said that the first few times she could not get a consult or a test on a COVID positive patient because of fear of contagion, she felt really demoralized. But then she rallied, and now she thoughtfully retriages her consults and advocates for her patients. So I mentioned these examples because they have a common theme. They all are situations in which there's a setup where providers know what to do, but external circumstances have limited their ability to do things in the best way possible. They may have felt ambivalent about the way a vulnerable patient was treated or a coworker was managed, or in extreme cases, they may have been swamped by guilt and grief or anger and disillusionment. So, what is moral injury? The concept of moral injury, like Laura mentioned earlier in the introduction, was first described in veterans returning from Vietnam with psychological damage, um, but their symptoms did not resemble the familiar post traumatic stress disorder that we know of and did not respond to the traditional treatments for PTSD. So, on closer assessment, it was found that the trauma that these people endured was not a result of a threat to their mortality, but rather due to a threat or ambivalence about their morality. They have questioned whether they were at their core still moral beings. They had acted in ways contrary to their beliefs or ethics, and this caused them some lasting psychological damage. So, to officially define what moral injury is, it is when we perpetrate or bear witness to or fail to prevent an act that transgresses our deeply held moral beliefs. And because our morals in medicine are our guiding principles that are at the center of our working lives as physicians and healthcare providers, a breach of a person's ethical code can have lasting emotional damage. So, what does it look like, or what are some morally injurious exposures that can happen in the context of COVID? So, as I walked around trying to interview people and find out what does that look like in their world, they seemed not to be familiar with the concept of moral injury, but they were quick to provide me with a myriad of examples about situations where more than one answer in their workplace could have been morally defensible, but none of the answers was ideal for patients or coworkers. So here are some questions. For example, who takes care of the COVID-19 patient? Is it a specific set of doctors in the hospital, or is it a specific location and whoever works there? And if only specific doctors are responsible for taking care of these highly contagious patients, are consultants excused from working there? And if there are already people in the rooms of COVID-19 patients taking care of them, like nurses, are other support staff best kept out of these rooms for their safety? And if they are invited to come to the rooms, have we prepared them to perform their jobs in the safest possible ways for themselves and for the patients? And while the institution is rationing PPE, who is entitled to using them and whose judgment is responsible for allocating them? Another highly contentious question that has gained a lot of attention has been withholding or carrying out elective surgeries. So, canceling elective surgeries may make perfect sense as it benefits us by protecting the patients from being vectors of infection, by preventing the doctors from infection, by preserving PPE, and offloading the healthcare system. But it also puts us at risk of hemorrhaging revenue for the institution. And when the institution loses money, we all lose. And um, of course, when we do not do these elective procedures, they may not seem so elective for the people that are not receiving them, whether it's a patient that needs that breast reconstruction after they've had a mastectomy, or somebody that needs a colon reanastomosis after they've had some staged surgery. So every time um, we are not doing a procedure for somebody that maybe perceive it as very important, there's that profound effect on both the providers that are not doing it and that are determining the patient's fate, and the patient that is not receiving it. And these are all setups for causing us to walk away feeling morally injured. So I hope that this is becoming more clear and more obvious that moral injury is tied closely to our medical ethics and also to organizational justice and our perception of fairness in the workplace. And it can be much worse in the context of COVID if we feel unsupported as we go into a difficult and unfamiliar event, or if we feel unaware or unprepared for potential emotional or psychological consequences of the work that we do. Of course, there's much more moral injury if we are working with vulnerable people or if there's a loss of a vulnerable patient. And just to be complete, I will say that moral injury, of course, predated COVID. It is usually happens when there's a conflict between our medical values and what the system demands from us, third party, other parties, other stakeholders. For example, when we have a electronic medical record system that conflicts with our priorities and demands more time of us than what we would like to give in favor of FaceTime with patients, or when the documentation within the electronic medical record system compels us to highlight aspects of care that we don't view as central to the case. So a lot of times when we have that kind of external pressure that gets in the way of doing things in the way that we feel is most ethical or moral for us, there's that sting of moral injustice. Often our work, um, the criteria by which our work is rewarded may not be conducive to us spending quality time with our patients or discussing a complex diagnosis with a sick patient or communicating with vulnerable families. Every time we walk away not doing these things, we feel a sting of moral injustice. So, how do we fix it? It is thought that the first step in preventing moral injury is really to use the correct language to describe it. So, if we are able to construct a framework of physician distress that spans moral dilemma, progressive to moral distress, and all the way to moral injury, and finally, potentially burnout, then we may be able to come up with effective prevention strategies. So who needs to be educated about moral injury? I would say everybody. So frontline staff need to be made aware of the possibility of potentially morally injurious exposure and the potential for their work during COVID to subject them to some psychological damage or psychological growth if we do things the best way. Leaders alike need to be made aware of the concept of moral injury and maybe guided to remove any unnecessary barriers that might de emphasize the value of human experience and relationships between patients and doctors. We do that by sitting at the table when COVID related policy discussions are taking place at the institutional and regional level, so we can work with the goal of maintaining a healthcare system that prioritizes healing and relationships and acknowledges the value of our morality, authenticity, and identity. So I'm going to take you back to the front lines one more time and share with you some of the quotes of people who have worked within their front lines to prevent moral injury from happening in their workplace. So this is a quote from somebody in the medical ICU. He said that our unit leadership has adjusted the MICU attending schedule in a way that eliminates night and weekend call and redeploys some of the off-service staff to help out. Another person from the hospitalist group said, we embarked on a community building initiative where we would order food for the whole unit to support local businesses and elevate the workers' morale. I really feel proud to belong to my division. One of the hospitalists said that we have banded together. We have united as a strong task force. We have started to have regular meetings, initially twice a week and now weekly, to share information, create protocols, and educate and support one another. Somebody said that our people, and in this case they were referring to nurses, have shown a high level of professionalism and psychological growth. We think more creatively now. One of the doctors said that he had choked up as he walked back to his home and found that the kids in the neighborhood have written on his driveway with chalk. Thank you, Dr. So-and-so, for being at the front lines, taking care of COVID patients. And finally, I was asking that same hospitalist whether or not they have some kind of setup where they have either formal or informal support for workers taking care of COVID patients. And his answer was, I may have been on the receiving end of an intervention phone call from one of our leaders who really wanted to know if I was sleeping well and eating well in the context of COVID. So these examples may feel profound for some or really basic for others, but I would say they share the important message of the importance of relationships and advocacy. So I'm going to end my talk by giving some recommendations of things that we can do amongst each other and in our own institution to try to mitigate the risk of moral injury. So the first one is really focusing on relationships, taking care of one another, facilitating team cohesion, because it's pretty common that physicians and clinicians and healthcare providers can get pitted against one another as resources shrink and as the stress levels go up. And we forget that we are all working towards a common goal. So it would help if we can always view one another with the presumption of charity and goodwill and unite for support, unite for mentorship and activism to make a change. So we have seen doctors in other institutions and in other states whose lives have been lost to death and disillusionment, and that would be a terrible loss for us. So another thing that we can do to take care of one another is to identify vulnerable people, monitor people who are more likely to be exposed to morally injurious events, whether they are taking care of the toughest or sickest patients, or they're the ones that are always having to break bad news or to communicate with families that are more vulnerable. So promote some sort of informal and formal support through one-on-one check-ins or group meetups, and remember that there's always the possibility of referring people to professionals. So there are some therapies that have been proposed to be most helpful in a situation like this, like adaptive disclosure, which is where forgiveness is received from a benevolent moral authority, could be helpful. Also, compassion-focused therapies and schema therapies might be helpful. There are no specific manualized approaches to treating mental health consequences of moral injury, but I would say take practical steps to identify and seek help for depression and anxiety. In our institution, we have the mental health hotline that was started in the context of COVID. It is manned 24 hours by our own mental health providers, therapists, and psychiatrists. There's also the COPE team that has been pretty active in helping the providers taking care of COVID patients. And of course, there's always the employee assistance program. So the last thing is really to establish a collaborative relationship with administrators to help the leadership empathize and also acknowledge the profound moral and ethical challenges that the teams will face in the context of COVID-19. And they have been pretty involved and sensitive to such issues, but some administrators may or may not have a very accurate view of the daily challenges of working with PPE or worrying about being exposed to the infection or losing vulnerable patients or denying them specific aspects of care in the context of COVID. On the other hand, we do not know on their side what are some of the kinds of spreadsheets that they're having to deal with, what are the consequences of shutting down the hospital for some kinds of patients, and the political implications and the financial implications of this pandemic. So a nice idea would be the physician administrator dyads as powerful problem-solving structures using the complementary skill sets from both a physician and a business person. And within these dyads, maybe we can remind administrators about moral injury and about the fact that patients are not merely numbers to medical providers, and that medicine is not merely a job, and that we do our best work when we apply our authentic and generous approach, and that we hope that the system would trust our wisdom to do well by our patients and by overcoming the system barriers. And that's all I have. So thanks for listening and thanks for tuning in, everyone. And please let me know if you have any questions.
All right. Thank you, Dr. Aburizik. That was wonderful. What a very nice balanced treatment of what could be a complex topic. And also, I really appreciated the ideas for what can be done. You know, not just that this is an issue in many places right now and has been in the past, but also that there are things that can be done about it. I wanted to ask you a question about moral injury and burnout. Can you talk about those two things and help us understand them a little more?
Yeah, so burnout is a term that has been used over the past decade to describe a compilation of symptoms that the physicians could develop, such as cynicism and exhaustion and depersonalization and feeling inadequate and ineffective in their jobs. It has really kind of gone out of favor because it suggests that the problem really resides within the individual who is deficient and unable to withstand the stress of the workplace. And recently, a lot of papers have been saying our physicians are not suffering from burnout, they have moral injury. And I guess the difference or the nuance is that moral injury describes a challenge of simultaneously knowing what you want to do, but being unable to provide it due to constraints that are outside of your control.
Thank you. That's interesting.
Mm-hmm.
I had another question about. So I loved the examples that you gave of how we are already doing a good job with supporting one another at our institution and how we're helping each other. I guess in terms of what sorts of treatments, you mentioned a couple that were sort of new to me as a psychologist. And you mentioned that there aren't any manualized treatments. Do you think that it would be fair for someone who feels like they're experiencing some of these issues to just seek help somewhere from, from the EAP, from a provider, and figure out how to get the right kind of treatment as they work with the provider, since we don't always know where to get these very specific treatments?
Absolutely. So we have that hotline when it first started. I was very curious to know, like, what are the protocols? What is the framework under which they are functioning? And one thing to really pay attention to is that moral injury is not a psychiatric diagnosis. It is, so it doesn't have to um, basically be treated in a specific way. So this discussion has been talking about preventing moral injury. Now, if it occurs, what kind of psychological consequences happen to it need to be addressed at their, at face value. And so I would say, if somebody has developed depression and anxiety related to that, there's nothing wrong with going through a supportive kind of therapy or a cognitive behavioral therapy or an acceptance commitment therapy and managing these patients with the frameworks that are familiar to us. I guess that's my answer, and I hope it's adequate.
That makes sense.
Mm-hmm.
You're right. I was kind of conflating two different things, maybe sequelae that could be the result of some of these experiences versus the actual experience, which maybe is talked about more in terms of like system change or examining what's going right and what's not going well and trying to figure out how to make it go better as a system.
Mm-hmm.
Yeah.
Thank you for the question.
Yeah. So we just had a question come through. Do you know, this is someone from the audience asking if specific jobs are more subject to moral injury and why, if you do know the answer to that.
So I think that obviously we have appropriated the term from the veterans. And so it started out in the military. We felt that it was fitting to some of the things that we're going through as medical providers. So I can imagine that any job in which we feel like we know what is morally right by us, and there are some external circumstances that are preventing us from doing things that way, would put us at risk of walking away feeling demoralized and asking ourselves if we were still at our core moral beings. I would say that we talk about it more in medicine because to many of us, working in healthcare provides us with a framework or a playground, if you may, in which we find continuous opportunities to live up by our values and care for others through practicing medicine. And so, if that is taken away from us because there are some pressures that make us not feel moral, that would take a very high toll. And so, I would never belittle or minimize the possibility that other specialties could challenge someone's morality. I think that that's certainly likely in all specialties. I can only speak for physicians because that's my background, and for healthcare providers. And I feel like our area is a great place to be human and be humane and be authentic. And it would be such a loss if that is taken away from us because of external pressures.
Thank you. As you were talking, in addition to the resources you already mentioned, like the EAP and the COPE team and things, I also thought of one more resource within the hospital, which would be to get an ethics consult. There are people who do that as a job, and they've been very helpful to many of my colleagues. And and to me at times. So that's all the time we have for questions. And so, in conclusion, I want to say thank you, Dr. Aburizik. We appreciate you sharing practical steps that we can take in response to the coronavirus. A recording of today's live stream, as well as links to additional resources related to this topic, will be included on the loop later today. Next time, we'll be joined by Dr. Jody Jones, who will be discussing the COVID-19 identity crisis, coping with changing roles at work and home. So until then, take care, and we look forward